Today, I'm going to talk about basics of investigations in pediatric neurology. I will start with the EEG. So why do we need an EEG or electroencephalogram? It's a supportive tool in diagnosing epilepsy. It's a supportive tool. I have highlighted that. And in patients where encephalitis or encephalopathy is diagnosed, the EEG may show changes. And in patients who are brain dead, the changes of EEG are useful. And to confirm a space-occupying lesion in the pre-imaging era, this was used immensely. So this is a machine that we use currently in the hospitals. So this has a monitor, the recording, the UPS and the printer and the video, and the electrodes are placed here. So you can see the closer view of that, and here how the electrodes are fixed into the machine as well as into the brain. So then in an EEG, when EEG is done, when a patient is there, you have to measure from his nasal or the nasal bone, bottom of the nasal bone, to the inion or the prominent place in the back of the head. And from that distance, you take 20%, 20%, 20%, and then place your electrodes. That's where you will get the correct placement of the electrodes, and then get the proper positioning. And also you need to take it horizontally as well, where you take it from the pinna close to the preauricle point, and to the other side preauricle point, and then measure it the same way, and then place the electrodes. So this is a nice picture of how they fix the electrodes with measuring of the distance. This is called a map or a montage. You can see that on the right, your right-hand side shows even numbers, FP2, F4, F8. So that means it's the right side. And on to the left side, it's odd numbers, 1, 3, 7, 5, etc. So now what are these names or the letters indicate? F is frontopolar, so that means it's right in front. And then just F is frontal, right? And then C is the central lead, and T is the temporal, and O is the occipital. So that it's easy to remember that these letters are used according to the lobe of the brain. And A1 and A2 are auricular leads. Usually they are functioning as a reference lead. So what about when you're recording the EEG, there is a bipolar recording and a referential electrode placement. Bipolar means the potential difference between two active electrodes. That means both these electrodes are active. So therefore you get a potential difference. When it comes to the referential, one electrode is inactive, like the auricular. Then you get the potential difference between one active and the inactive, so that you get the net result of the active one. So these are the basic waves: beta, alpha, theta, and delta. Beta is when you have a frequency of 13 to 30. That means it's a fast activity. Alpha is the normal rhythm, where it goes from 8 to 13 hertz. That means per second you have 8 to 13 number of, if you count this, 1, 2, 3, 4, 8 to 13 number of waves. Theta is a bit slower. It is 4 to 8 hertz. And delta is even slower. It's 0.5 to 4 hertz. Then while we are doing the EEG, we have some provocation techniques to improve the yield of the EEG. One is hyperventilation. You all know that in certain types of epilepsies, hyperventilation brings about discharges. And then you use sleep by using chloral or melatonin. And induction of natural sleep following a sleep deprivation. That means the child wakes up early the previous day and then falls asleep naturally during the EEG. And then the photic stimulation, that is you focus light, which is at different frequencies to the child's eye. So this is what this technician is doing. She focuses the light flashes the light onto the child's eye. And when it comes to EEG, there are several things that we have to know. The abnormal and the normal waves and patterns. So spike, this is a spike. That means it's a very sharp and a tall waveform. Sharp wave is slightly more broader and a little shorter than the spike. Polyspike are many spikes in one go. And hypsarrhythmia is that there are chaotic pattern, there are continuous patterns. So, and there are some EEGs which shows, now this is a hypsarrhythmic EEG. You can see that it's a very chaotic type of EEG where different spikes and waves and in different areas, and also some areas where there are no activity or less activity, which are called attenuations. And this is a normal EEG. And when it comes to the seizure, you can see that there is a polyspike and wave occurring in a myoclonic seizure, but it's very brief. And you can see the artifacts of the muscle. So this is the EEG for juvenile myoclonic epilepsy. When it comes to encephalopathy or encephalitis, you can see a very slow wave. Those are called delta waves. So if this is 1 hertz, 1 second, you can see 1 and 2 waves. So that is very slow. So that is called the delta wave. And generally, you get a generalized slow wave pattern in certain encephalopathies and encephalitis. And if it is focal, like in herpes simplex encephalitis, you may get a focal slowing activity. And sensotemporal spikes in benign Rolandic epilepsy, that's another pattern where you see temporal and the central areas and the frontal areas have spikes in one side mainly. Other side only has propagated changes and or maybe normal. Then the absence epilepsy, childhood or juvenile absence epilepsy, where you will see a short burst of discharges generalized, and within 1 second you have 3 to 4 spikes. Generally, it's a 3 per second spike and wave activity. So it's very brief. Before the onset of the seizure, you can see the EEG is normal. And then in a group of children where they have continuous spike and wave activity and they are continuously having seizing activity in the brain, they are the ones who have epileptic encephalopathy. And these children kind of have seizures, subclinical seizures, and they need to be treated. And their development and the academic activity are poor. In Lennox-Gastaut syndrome, you can see a paroxysmal fast activity in the EEG. And then in sleep, you will see a continuous spike and wave activity. What is video telemetry? Video telemetry is where you record your seizures over a period of time. Generally, a normal interictal EEGs are shorter duration. Some may vary from 20 minutes to 1 to 2 hours. However, in video telemetry, it's a longer duration. Usually, they do it for 3 to 5 days to get the better yield. They need inward care and sometimes high dependency. When one is on a video telemetry monitoring, some might discontinue the medicines to induce seizures. These are used for localizing the lesion in pre-surgical workup for epilepsy and also to demonstrate whether it's epileptic or a non-epileptic event where it is difficult by the video or the naked eye. So the other investigations are nerve conduction studies, where a series of surface electrodes are placed at different locations along the specific peripheral nerves, and then the nerve is stimulated at one site and recorded to determine the nerve is conducting properly. So these are pictures of the equipment where it is stimulated, and then it's recorded in the machine, recorded at different areas. It's recorded here. So you can decide whether the nerve is functional or dysfunctional, sensory involvement, etc. They are recording, and the stimulation is here, and you can see the waveforms. So the indications are to diagnose peripheral neuropathy, entrapment neuropathies like carpal tunnel syndrome, Guillain-Barré syndrome, myasthenia gravis. Especially in myasthenia gravis, you do repetitive nerve stimulation. And then at the same time, you can use the needle EMG or electron myography. And that will also evaluate the electrical signals. And they are directly inserted into muscle concern, and they will check the muscle activity when resting and when contracted. These are the indications like myopathy, muscular dystrophy, anterior horn cell disorder. And in myasthenia gravis, a single fiber EMG is useful to determine whether the child is having myasthenia gravis or not. So this is how the needle comes and places in the muscle that is concerned. Then we have neuroimaging, the ultrasound brain and spine, CT brain, CT angiogram, MRI brain, MRI angiogram, MR venogram, MR spectroscopy, PET, and SPECT. So in neonates, we use the ultrasound brain to detect hemorrhages and any cystic lesions and any form of abnormal structural deformities, but it may be limited view sometimes, and also it's observer biased. And then it is commonly used to diagnose spinal defects at the neonatal and the early infancy. In the CT brain, you can decide if there are hemorrhages like this. And a subarachnoid hemorrhage can be detected, very subtle one and a very advanced one. And then you can detect hemorrhages, infarcts, and tumors as well. The MRI brain will be more useful in detecting tumors and hemorrhages, and also the infarcts that are old. These are specific changes in certain diseases like adrenoleukodystrophy. Again, some of the changes that may be seen in tuberous sclerosis, and then different demyelination conditions like ADEM and multiple sclerosis. CT angiogram is used to detect vascular anomalies of the CNS. Like in the case of Moya-Moya syndrome, you see a puff of smoke appearance when you do the CT angio, especially with the patients with recurrent strokes. MR angiogram is useful to detect if there are any narrowings, especially again in varicella and other conditions that may cause strokes in children. MRV or the MR venogram will detect any venous filling defects, so that whether there's a venous sinus thrombosis. This picture shows what are the venous sinuses that we look for, and some of them with filling defects. Here you can see a nice filling defect in this sinus. SPECT is a special technique that is used in patients with epilepsy to identify the lesion. While they're on video telemetry, when the seizure begins, there is a special dye that is injected to them, and it is believed that this dye is taken up at the epileptogenic zone, so that you may see a bright signal in that area, and then subsequently you repeat the film in 24 hours to see that the activity is less. So that way you try to determine the epileptogenic zone and the focus or the area to do the epilepsy surgery. Is a PET scan. The PET scan will allow us to identify again the area of concern, especially with the hypoglycemic, because the dye that is used specifically takes up the areas that are taken up, that are lighted by the hypoglycemia. So this is such an area where if you can see the MRI, that will also show some changes, and it is confirmed with the PET. Generally, it can be co-registered with the PET scan. The MRI scan is co-registered with the PET scan. So those are the special investigations that are being used in pediatric neurology. And some of them are used in combination and some of them in isolation. By far, EEG is the commonest one that is being ordered. Thank you very much.